Terry, I'm going to also just again put out a plug. So we'll be um, sending out the ballot for IAPIC for the board. We'll be sending it out on Monday, and we'll have the elections open from for the entire month of November. So we'll have them open from November 2nd until the 30th, which I think is a Monday as well. So be looking for that and make sure you vote. And we've got a full ballot, so it'll be exciting to have that coming out next week. And with that, Tati, I'll let you introduce our speaker for today.
Thank you, Trent. So for those that were not here last time, I'll just do a quick introduction here on Jim. And Jim is a medical laboratory technologist by training, and he worked in hospital microbiology for 19 years. He first became board certified in 1990, so 30 years ago, has a lot of experience, and has worked in or consulted to acute care and acute care, including behavioral health, health clinics, such as medical, dental, optometry, also schools, and even the funeral industry. So Jim joined Diversity in 2015 as their senior clinical advisor, infection prevention, and he lives just outside of Kingston, Ontario. We're very glad to have him here and to present for us and present on cleaning once per day is not enough. So Jim, the time is yours. Thank you.
Thanks, Daddy. I appreciate the introduction. And thank you, everyone, for joining in on a Friday afternoon. We got a nice, bright, sunny day here, but cool. I think we're sitting at about 38 degrees. And I hope you're all doing well. I'm excited to be doing this presentation. I was talking to your board there before I got started. This is a talk that's near and dear to my heart. I hope you enjoy it and get something from it. As mentioned in my introduction, I do work for Diversity. They cover my, this still says travel and accommodation. I'm not going anywhere. They cover my salary, and they do know of this presentation. There's a lot of people that went together to help develop this presentation and this concept. So what I want to do in my objective is review the complexity of what has to happen for a healthcare-associated infection to occur, and I'm going to do a very high-level look at that, and then talk about things we need to look at around our daily practices that happens within a healthcare environment, and then offer you some suggestions on how to keep our patients even more safe than we're trying to do right now. Because right now, there is not one simple answer, there's not one silver bullet around HAI reduction. It's a rather complex problem that we face on our daily basis in infection prevention and control. And I actually put together a presentation with one of my regional managers who's a math nerd. And he came up with this concept of, can we look at a healthcare-associated infection as an algebraic equation? You'll recognize your standard algebraic equation where you have a problem and you have numerous f at n that are components that make up the problem. And he was always saying to me, if you can't solve for a variable in a mathematical equation, you must control for it. And part of the problem we face in infection prevention and control is we have no control over the susceptible host from our chain of transmission. If we had nobody that could get sick, we wouldn't have any hospitals, right? So we can't control for the susceptible host. So when I look at my healthcare-associated infection prevention, this is the equation that we came up with. And what this stands for is that healthcare-associated infection prevention is a combination of patient acuity, hand hygiene practices, antimicrobial stewardship programs, clinical practices, fecal waste management, and environmental disinfection. So as that previous slide said, there's a full 45-minute presentation that you can go to our website and listen to on this. But basically, in terms of patient acuity, I'm talking about, if a patient's on a ventilator, they're much more susceptible to getting an HAI than a patient that's not. If they have a portal of entry, POE, if they're young or old, if they're on antibiotics, if they have other comorbidities, all of these makes them more susceptible to a healthcare-associated infection. In terms of hand hygiene, do we have the right product in the right place? Are we auditing our hand hygiene practices? Does our staff understand the 5 moments of hand hygiene? Do you have champions on each of your nursing areas that help support the importance of hand hygiene? Have you even considered doing something like patient hand hygiene? And does your family and visitors understand the importance of their hand hygiene? Our antibiotic stewardship program is getting a lot of attention these days. I just noticed that we're starting to see a lot more issues around antibiotic use as patients get COVID and develop other problems. So do we have the right drug by the right route for the right duration at the right dose? Do we have restrictions on our formulary so that doctors don't order very broad spectrum antibiotics when they could be using something of a narrower route? Our clinical practices, do we have a good skin prep before we provide surgery? Do we decolonize patients before surgery? Do we decolonize their nares? Do we give the prophylactic antibiotics before surgery at the right time? Do we have bundles in place in terms of line insertion and other things that we have in place? Because all of these have been shown to help reduce the risk of getting a healthcare-associated infection. I spend way too much of my life talking about feces. For those of you that are new in infection prevention and control, trust me, it all comes down to feces. So fecal waste management, generally when I get consulted in my role as the Senior Clinical Advisor in Infection Prevention for Diversity, I always ask people that are having trouble with C. difficile or VRE, what do you do with your fecal waste containers, your bedpans, your commode buckets? Because if you're not using a machine to wash them, thermal disinfection, or a machine to macerate the paper bedpan, or if you're not using a liner bag, you're going to have trouble, ongoing trouble with anything that is spread by feces. And I'll talk about that further in this presentation. Does your staff have personal protective equipment to wear when they have to handle feces or assist the patient with defecating? Do you have a no rinse policy so that bedpans and commode buckets are not rinsed within the patient bathroom, because we know that spreads stuff? Do you have a good written protocol on how to change a patient out of an incontinence product? My son, the RN, I asked him this one day and I got a funny look from him because there is no written policy for this. We all sort of do it as best we can. And then the whole environmental disinfection. Does your EVS staff know what they have to clean and do you audit it? Does our nursing staff and care staff know what they have to clean and do we audit it? Does everyone that uses anything in the healthcare setting know what they have to clean? Can your family assist with wiping down some high-touch surfaces around the patient? Do you have a product the staff are very happy to use, or are they afraid of your product or don't like it because of the scent? Does your staff have PPE available to them if they need that to use the product that you're utilizing in your hospital? Are you checking to make sure the contact time is adhered to? If you've got a 10-minute or a 5-minute or a 3-minute product, that all needs to be reapplied. If you dilute your disinfectants, do you check the dilution that is actually working? Is your product compatible with the surfaces that you have to disinfect? And the final one on this list of things that can contribute to HAIs is, do you have enough resources in terms of bodies to actually do the cleaning? So if you actually count those up, in my presentation, there's about 36 different factors.
In the last week, fourfold over 2 weeks ago.
Oh, we got somebody with an unmuted mic. Thank you. So my question, or there's actually 36 factors that can lead to healthcare-associated infections. The whole environmental risk is well elucidated now. This paper by John Otter looked at other papers where the risk of you acquiring the organism of the guy ahead of you. So if you look at the bottom study, if a patient had multi-drug resistant Acinetobacter, you stood a 3.5 times higher chance of getting Acinetobacter if you followed that patient into their room and into that bed, even after the terminal clean. So with that kind of a statement, would just really good EVS be enough to cut down on HAIs? So there was this paper that was published back in 2017. John Boyce was the lead author on this, and he was doing a study looking at switching. It was sort of a study where he went from using a quaternary ammonium-based disinfectant to using an improved hydrogen peroxide. And part of his study was the rooms would only be counted in the study if the pickup of the fluorescent dots was at 80%. So the rooms are being wiped at an 80% compliance, and if it wasn't, you had to go back and re-clean the room. So this is scrupulous infection prevention to me. And his results were pretty good. Compared to the quat wards, when he switched to the improved hydrogen peroxide, he managed to drop his infection rates for VRE acquisition of bloodstream infections, for his MRSA and bloodstream infections. His C. diff even dropped from 12 cases to 6 cases in 6 months. So they went from 119 cases down to 86 cases. And that was 23% fewer cases. But if I remind you, this is with 80% compliance of wiping the surfaces, which to me is almost perfect environmental surfaces. And he still had 86 infections occur in a 6-month period with that kind of attention. We also spent a lot of time looking at hand hygiene. So this is a paper by McCalla that was in the American Journal of Infection Control, where they claimed that red wavy line that goes across the top here, they were claiming that they were hitting 95% compliance with their hand hygiene, and this was electronically audited. So what they increased was the opportunities to do hand hygiene. So you got a notification when you should do it. And their results were impressive also, right? They dropped their CAUTIs from 2.2 per thousand catheter days down to 1.21. Their CLABSIs dropped. Their Foley, they were doing a multifactorial thing with the Foleys. They dropped it from 2.01, brought in a protocol, dropped it to 1.58. They got it down with the increased hand hygiene compliances down to 1.15. They still had infections with hand hygiene being at 95%. So when I look back at my equation of 36 factors, hand hygiene accounts for 7 of these. And if we just focus on environmental services and say we need to get a better job done in EVS, that really only controls for 9. So there's many areas that we have to look at around our HAI prevention, beyond just good hand hygiene and beyond just good environmental control. And I put this into a pie chart. I can't tell you how much of each of those 6 factors contributes to prevention of HAI. They all will vary by hospital and by practice and by patient. There's so many things involved there. We do know that good cleaning and hand hygiene can help reduce our problem by, let's say, 20 to 40%. But what else can we do? So if you actually look at what goes on in the patient environment, EVS comes in and cleans once a day. Here in Ontario, if we have a patient with C. difficile, they come in a second time a day and does high-touch surfaces. But we're still generally only cleaning. And the question always is, what happens during those other 23.5 hours? So I've got a video here. I'm just going to click on. Don't worry about the sound. They're speaking Norwegian. And there's music underneath. I don't think you'll be able to hear it. You might through my microphone. So I think you get the gist of that. That video is available free. When I first saw it, it was on YouTube. And because I'm not under 15, I couldn't figure out how to download it. So they put it up on Vimeo. It is available. They have a second video that's much the same about moving multi-drug resistant microorganisms. But what that showed is patient rooms are very busy. There's a lot of things that are touched. This study by Cohen looked at what goes on during waking hours in a patient's room. So they observed between 5 a.m. and 8 p.m. What happened in the ICU in a med-surg unit. And they found on average, there's 5.5 entries per hour, on average. 28 was the maximum, which I would assume was up in the ICU. They had about 3.5 different staff an hour entering. So during waking hours, if you do the multiplication of 15 hours at an average of 5.5, there's about 82.5 people that would come in. And it's what you would expect. Well, the first one's what I would expect, nursing staff coming in, but almost a quarter of those people that broke that threshold going into the patient's room were personal visitors. Then you had the other people that help provide care. They asked the nurses, how many different people do you think you see per hour? And the range was 0.5 to 18 per hour. On average, the nurses felt they saw 4.5 different patients an hour, which is a pretty busy in and out of the room. And they observed what was happening. They found that about a third of the time that they're in the room, they only have contact with the environment. And there's other things they get touched while they're there. The graph is very interesting because they looked at blood and body fluid. And nurses, during their study and observations, had contact with blood and body fluid 15.6% of the time, whereas visitors had contact almost 20% of the time. Now, I don't know about you, but I did no training with my visitors and families on standard precautions. And during this observation, they found that the visitor family, because this was mainly in a pediatric area, they only used gloves a third of the time. And hand hygiene was not great. So that helped wake me up a little bit to what's actually going on. For those of you that actually do hand hygiene auditing, with the nurses, a third of the time, they didn't touch anything. And nothing was touched in the room. So if I never stood directly looking into the room and I did hand hygiene auditing. I thought if you were in there for a period of time, I assumed you touched something. But in this study, they actually may not need to do hand hygiene on the way out unless you have a policy of gel in, gel out. There's another study that I still consider the seminal study on what is a high-touch surface. And Kirk Husledge up in North Carolina did this study where he just watched what people touched when they went into the ICU. And you can see the top 3 surfaces that were touched per interaction, which just means they walked into the room, were the bed rails, bed surface, and supply cart, were high-touch surfaces. In the med-surg unit, the high-touch surfaces were the bed rail, over bed table, IV pump, and bed surface. That was the high touch. And then other things were touched. And he kept track of that. On average, when somebody walks into the ICU, they are going to touch 44 things. When they walk into a med-surg unit, they're going to touch 15. So with the bed rail being a high-touch surface, if we combine the Cone study with the Husledge study, we have 5.5 room entries on average per hour. With every time you go into the room, you're going to touch the bed rail 3.1 times. Over 15 hours, that bed rail could be touched 256 times. And as I said earlier, generally we're only cleaning once a day. And I don't know if you've seen the studies where they show that the probability of actually getting a bed rail wiped is around 50%. My question always is, what happens to the other 255 times that bed rail is touched? Now, John Boyce, Dr. John Boyce is actually on contract with my company. So he phoned me one day going, Jim, I saw your presentation on cleaning once a day is not enough. And he said, you really can't combine 2 studies like that to come up with 255. And I said, well, John, even if that's high, the bed rail, if it's touched 125 times a day, is still only cleaned once. And even if you go half that, if the bed rail's touched 60 times and only cleaned once a day, I think we've got an issue. So yes, I shouldn't combine the numbers like this, but even 60 times a day is a lot. I read another paper by Jinadatha where they looked at what happens over the course of 6 days. And you can see here that the bed rail was touched 375 times over 6 days, which is about 60 times a day. The overbed table was touched 223 times. What was concerning in this paper is the workstation on wheels and the vital machines were touched 847 times in 6 days and was only disinfected 17 times in that 6 days of observation, which if you like math is about 0.3% of the time that it's actually used. And they also monitored what was touched and what was the most common sequence. And the most common sequence was touching the patient and then the bed rail. The second most common was touching the bed rail and then the patient. So there's lots of touches that are going on. And I actually found another paper out of Europe by Clack where they put a GoPro camera on people's foreheads and then looked at the video as to what they touched. And they were auditing for hand-to-surface exposures. And that was happening 14.2 times per minute, or something is being touched every 4.2 seconds. Hand hygiene was being done 3 minutes, and a lot of the hand surface exposures were the healthcare worker touching themselves. So they looked at what was the risk of that happening. So they thought, well, let's try to classify them as a colonization event, where you touch something inside the patient environment or the zone where you may have brought bacteria in, but it's not really critical. It's not going to make the patient sick. And that was happening once a minute. And hand hygiene, they audited for the colonization events, was at 4.8%. They also looked at what could be an infection event where you actually touch something that is critical for infection risks, like touching a wound or a catheter or a mucous membrane or an invasive device. And they found that that was happening approximately once every 1.4 minutes, with hand hygiene not being done very frequently at all. Back in that video, when I watched it earlier today, I counted 23 things that he touched in the course of that video. So they're not far off. That video is not very long, and if I multiply that by about 4, that's about right, what they're actually touching. So how many times a day does your staff, not EVS, disinfect something? When was the last time you saw a healthcare provider actually wipe down the side rails or an overbed table? It's probably not very frequently. Maybe if it's grossly soiled, you might find your clinical staff doing that. We know where our hand hygiene really is when we actually do auditing, true secret shopper. When I was in the hallway, my hand hygiene auditing was a lot higher because they would come out of a room, not do their hands, see me, and hit that next hand hygiene dispenser, which I still counted as they got their hands clean. I was happy. We really need to look at what goes on in our environment. That's a lot of touches that are going on. And if we're only doing it once or twice a day with EBS, this is where we came up with the concept of maybe we need to look at point of care disinfection. We have point of care hand hygiene. Maybe we need point of care disinfection and look at certain procedures that might necessitate us actually doing disinfection. So my simple standard precautions, the way, and I was just talking to another IP outside of Idaho today, and I said to her, the way I talk to my staff about standard precautions is, if they are leaking, protect yourself and limit their movement. If it is dirty or you used it, clean it. So that's standard precautions in 20 words. If they're leaking, productive cough, diarrhea, wound leakage, protect yourself. Put on a gown and glove because you have to address something that's leaking. Limit their movement, that's contact or contact droplet. And then if it's dirty or you used it, clean it. This is another statement that I live by, is it's everyone's job to disinfect, but it is not everyone's job to disinfect everything every time, right? It's pretty simple there. And why do I say this kind of stuff? Well, being a microbiology tech, I know that a couple of our body substances are predominantly organisms. And we're finding this out now with COVID, how many bugs are actually present in saliva. Feces can have 1 × 10 to the 12th grams, organisms per gram dry weight. Saliva can be 1 × 10 to the 8th per ml. Now, an ml is not very much, and remember this, I used to like giving these numbers to university students during orientation, so they didn't go out and share saliva with other people, hopefully trying to keep everybody healthy that way. That's a lot of bugs. Plus, I was at a SHEA conference where they're talking about the human microbiome, and they were saying to us, everyone in this room is going to shed 1 million skin squames the hour of this presentation. Each skin squame can have 15 bacteria, so you're all going to leave about 15 million bacteria in the room here. Which is a huge amount of microorganisms going in. Yes, they're all pretty harmless. They're all skin flora and that kind of stuff, but there's a lot of stuff that happens in the room. And if you look at what happens to our bed rails and controls or the overbed table, is when I started going to the literature. So I found easily 22 studies that looked at different microorganisms, usually during outbreaks, what was found on the bed rail. You can see the organisms, VRE, MRSA, Clostridioides, crab, resistant pseudomonas, multi-drug resistant organisms. Some studies just looked at the amount of bioburden or bacteria that was present. Even Candida auris was found on a bed rail in an outbreak described by Escandon. If you look at what can be found on an overbed table, I just listed 13 studies here because they weren't that hard to find, that we can find microorganisms in the environment around a patient. So if you start looking at other papers, I started looking at, well, what happens when we do something aseptic? Let's say when we're actually doing, say, wound care. And I found 3 papers that talked about finding carbapenem-resistant Enterobacteriaceae. They associated it with the healthcare worker contamination if you provided wound care. It was statistically significant how much soiling happened when we did aseptic work with a wound. Morgan, they linked it back to multi-drug resistant Acinetobacter was found because of anything to do with the wound dressing. The Surgeon paper was looking at just bioburden, but they felt it was frequent during dressing of a colonized wound with tissue loss. And the paper went on to state something to the effect of, we don't really need to clean before, but we definitely should clean after. That statement's in the paper. I told you what was in feces, right? The huge volumes. Well, the paper by Mayer actually looked at the colony-forming units of VRE per gram of stool. And they found in their study it went anywhere from 2,300 to 1.6 billion colonies in 1 gram of stool. Now, a gram of stool is about the size of a sugar cube, right? I'm sure you all roughly know the size of that. And you're probably wondering, well, what's the average bowel movement? Well, I've got those numbers for you. There's a paper looking at cancer and fiber in the colon and rectum, and they looked at the average bowel movement was between 72 and 470 grams, or 2.5 to 16.6 ounces. And in case you're wondering, the most constipated group on the world is Scotland. They led with the average bowel movement being tiny and constipated. United States in 2 different studies placed number 3 and number 5. And Uganda, where they eat a high fiber diet, was the best in terms of the volume of stool that's passed. Just a little aside of stuff you really don't want to know. Dr. Boyce did a study where he was looking at liquid stool that was coming down for testing for C. difficile and cultured it for MRSA. And he found again that it could be present in heavy growth, 10 to the 7th to 10 to the 9th colony-forming units per gram of stool. And that's a lot, in case you're wondering. That's a lot of MRSA could be present in feces. I never thought it was a colonizer of feces, and I had this paper brought to my attention after doing another presentation on fecal waste management. The paper by you here looked at what they could find on the bed rails, bedside table, and bed controls with known positive C. diff patients, or a patient where we had no record of them being positive for C. diff, how many were present on, or how many sites were present after routine cleaning and after terminal cleaning. So even if there was no known positive C. diff patient after terminal cleaning, they could find C. diff spores on 4 to 6% of the surfaces that they tested. So that's a little scary too, as to how much gets in there that we may not be picking up with our once daily clean. And part of this is why we tend to flip out about C. difficile, and there's a lot of places that want to use a sporicidal everywhere. This is a protocol I've come up with that I share at every presentation I do, that we need to be very consistent on how we clean up feces. I don't care what the patient's status is, but if I find feces on a surface, on a bed rail, on a floor, if the patient has an incontinence problem, let's wipe up the gross spill, get rid of that, or send it off to laundry, disinfect that area where the stool was, which will also help to clean it, allow the contact time for your disinfectant, and then use a spot sporicidal. I don't think we need to do the entire room. I think we need to clean up feces very consistently. I would appreciate comments on that in the comment box if you think that's a good idea, bad idea. I looked at also what happens when we actually suction a patient, or if a patient actually has a trach in place. And sure enough, the Zelichowski paper, I loved it, that they referred to suctioning as creating a bacteria-laden aerosol. So remember that as we work with COVID. Cobley, environmental contamination occurred up to 1 meter away from the suction port. Choi, open suctioning is the main cause of contamination during their outbreak. And then I looked at, well, what were they finding? Well, they were finding things like CRE. In their outbreak, Rock said it was, they could link the CRE spread to caring for a patient who had a trach or an endotracheal tube. Morgan described 2 different outbreaks with multi-drug resistant Acinetobacter, where they said the care or use of an endotracheal tube or tracheostomy site was linked to the spread. And the second paper, they talk about the respiratory tract being heavily colonized with multi-drug resistant bacteria, and that contact with the respiratory equipment could have helped increase the risk of moving the organism around. I even looked at what happens when a patient bathes within their bed space. This was sort of fun trying to find references for this, but they were looking at the basins. The Johnson paper was looking at switching from using a wash basin to going to the pre-wetted wipes that you heat up and then wipe the patient down with 6 or 8 different wipes. And they were finding that the aerobic colony count on these basins was almost 100,000 organisms when they were testing it. It was a median, a little bit lower, but in that paper, they had a reference to bath water having greater than 10 to the 5th colony-forming units per ml. Now, I can't get the Shannon paper. The journal that it was published in is no longer available, and I just can't get a copy of it. The Rhodes study, though, was looking at using bath water or gray water for irrigation. So they were culturing standard gray water, shower and bath water, and we're finding range from 10 to the 5th to 10 to the 10th colony-forming units per 100 ml. And that you could find fecal coliform, 10 to the 4th to 10 to the 6th in bath water. So if we bathe a patient like old school using a basin and a washcloth, there's a lot of bacteria that could be present in that water and splashed into the patient's environment. I get asked a lot about floors. Jim, what do you think we should do with floors? Should we clean, sanitize, or disinfect? I actually did a presentation on all of that. But this paper gets talked about a lot, the Deshpande paper where they cultured floors to see what was on them, and then they tried to look at what was on the floor, and are they truly a reservoir for transmission of healthcare-associated pathogens? So they found the black bars are what they found in the rooms of C. diff patients. So the black bars, they found 55% of the time you could find C. diff spores on the floor. They could find MRSA 30% of the time and VRE 30% of the time in the rooms of patients who had C. diff. The red bars, the patient didn't have C. diff, and they're still finding spores on the floor 45% of the time, and MRSA and VRE. So that was their culturing. Then they looked at what's on the floor. So they went around, looked at 100 rooms, and 41% of them had something on the floor. And it varied from personal items that are listed here, medical devices or supplies that were going to be used on the patient. They even found bed linen and towels on the floor. So when they found something on the floor, they put a sterile glove on and picked it up and cultured the glove. And they found that, yes, you can move stuff from the floor. MRSA transferred 18% of the times that they did this. VRE transferred. C. diff didn't transfer as well, but they could show that you can move stuff from a floor to a patient. And there was just a paper, I just added this to this presentation this week as I got together, and this was just published this month in the American Journal of Infection Control, where what they're looking at here is the presence of extended spectrum beta-lactamase producing and carbapenem-resistant gram-negative bacilli. And they showed a lot of percentages here at the left-hand side and the surface that they found them on. So they could find it within 0.9 meters is about 3 feet, about a yard. So they could find, after meal assistance, there was organisms that were being spread, urinary catheter care, there were organisms being spread, ostomy care, bathing, wound care. You can see the stuff where they actually found bacteria in the environment. So I think this helps explain, what are we missing? What's going on here, right? We're getting our hand hygiene rates as high as we can. We're doing good auditing of the environment. We're supposed to be doing it anywhere. Is there more that we can do? So I'm going to remind you, it's everyone's job to disinfect. It's not everyone's job to disinfect everything every time. So when should we ask for more cleaning or disinfections to be done? Are there moments that we can target? And this takes me back to 5 moments for hand hygiene. Why did we come up with this, right? We wanted to try to focus our healthcare providers, our healthcare team, everyone that works providing care on 5 moments we absolutely have to see hand hygiene. And you should all be able to recite these. Normally when I do this, I don't look at my screen to show that I know what the 5 moments are. Before touching a patient, before clean aseptic procedure, after body fluid exposure risk, after touching a patient, after touching the patient's surroundings. Up here in Canada, those of you that pop over the border to find out what we're doing up here where we have minimal COVID, we only have 4 moments because our moment 1 is before touching a patient or their environment, and our moment 4 is after touching a patient or their environment. So we've cut it down to 4. So if I put all this together and I look at all the evidence I just presented to you on what happens in our world during care, I think there are some specific targeted moments when we need to provide some environmental disinfection beyond once a day. The first moment is before we put anything, food or drink, on an overbed table. I showed you all the stuff that can be found there. And I think this is something that we do daily for patients that are going to eat in the room. And I think it's vitally important that we actually do disinfection. Moment 2, before and after any aseptic practice. So anything to do with wounds, lines, catheters, anything like that, we should be disinfecting before to create a clean space, and after the aseptic procedure. After any procedure involving feces or respiratory secretions within the bed space. I've shown you how much organisms can be present in feces, both MRSA, VRE, C. diff shows up all over the place. Respiratory secretions, if we're suctioning patients, helping them cough, I think we need to disinfect after. Moment 4, after patient bathing within the bed space, because as you saw, there's a lot of microorganisms that can be present in bath water. And moment 5, after any object used by or used on a patient touches the floor. So when somebody walks into the room and the patient's sitting there going, can you hand me my cell phone? It fell off the bed. It really should be disinfected before it's handed to them. I think this would help eliminate a lot of the worry about what's on the floor if we don't touch the floor, or if something touches the floor, we disinfect it. So is this new cleaning a new idea? Well, in the outbreak papers I was looking at, the Acinetobacter baumannii outbreak, Choi was pointing out that it's the people that move back and forth. Other healthcare workers, such as med technologists, radiology techs, physical therapists who care for patients in both ICUs, could have been a source of transmission. So they're taking it from the environment in one ICU, moving it to another one. The Attaway paper commented that to keep the bacterial population in check on the bed rails, you need bi-hourly cleaning, twice an hour, every 30 minutes, or every 2 hours. I don't know which way you want to go on that. Ali paper, looking at staff, this was mathematical modeling. They were saying regular wiping with antibacterial wipes can be cost-effective means of maintaining low numbers of bacteria near the patient. And the Lay paper, this is the mathematical model, sorry, we're saying to wipe high-touch surfaces 3 times per hour to reduce MRSA. Because we get so focused on this once a day and just hand hygiene, these were papers pointing out we need to look at our environment a lot closer. And even this paper that I showed you from MIDI was pointing out all of these times that they were finding bacteria. Weirdly enough, on the 5 moments there, we actually had this concept published as a paper in the Joint Commission's Journal of Quality and Patient Safety. And in the references, when I share these slides with your team, in the references, you can download that paper for free from the Joint Commission's Journal of Quality and Patient Safety and see how it lines up. This paper didn't reference it, but again, my paper came out in the middle of a pandemic, so I don't think a lot of people have read it. This is very familiar to staff. It really should be. This is something in Canada we have to teach annually, and it falls into a lot of the diagrams that we used to have. If you do the 5 moments for point of care disinfection before placing food, after and before aseptic procedure, anything to do with feces or respiratory, after patient bathing, after any object used by or on a patient is found on the floor, it all looks familiar, and it lines up pretty good with the 5 moments for hand hygiene. So it's not a real new concept, but I think biggest pushback you're going to get is, well, where do you want to begin? So we took this concept to a IAPIC conference many years back now, 2016, I think it was. And we talked about the importance of cleaning, and there's a lot of pushback from the RNs, some of the RNs, saying, that's below my RN to clean. And I know if you come out with a concept of, we need you to wipe the surfaces a little bit, there'll be the pushback of, we have EBS for that, and then you give them some of these statistics. But we also designed a little chart to say, well, how many times a day do you feed a patient? If they're vented in ICU, that's 3 wipes you're not going to use. Say you've got a med-surg patient with no wounds, you may feed them 3 times a day. If they're diabetic, they get a snack, so that might be 6 extra wipes. Oops, sorry, page up. How often do you do an aseptic procedure on a patient with no wound? You may not actually do one. They may defecate once a day. You don't have to suction them. You may assist with bathing. We may only be talking 8 or 9 extra wipes a day in a med-surg patient with no wound. But we came up with this chart so that you could work with the healthcare team, saying, well, who actually drops the food tray? Is that an RN duty? Yes, they do the aseptic practice. Do they assist the patient after defecation, or do you have care aides that can do this? Like, there's a way of looking at this to not make it so onerous. Carol Calabrese, who is an RN, she's the other clinical advisor for diversity. She and I sat down and with an ICU patient that we do head to toe every hour, and we suction them during that head to toe, and they've got C. diff diarrhea, and they've got wounds all over the place. I think we got up to 50 extra wipes when we looked at it, and that's a critically ill patient. We were trying to come up with the worst possible scenario. So there will be a range. There are some coming up here. But part of this is you have to have the disinfectant where care happens, right? We did this with hand hygiene. So you need to take a look at your disinfectant, because if it's safe enough, there are disinfectants out there that have a 000 or an EPA toxicity rating of 4. Midovac talks about some of the disinfectants that can fall into this category, but you want something that's not harmful to health, it's not flammable, there's no physical hazard. It would be ideal if you can get a disinfectant that you don't need to wear gloves or other PPE, so that family can actually grab a wipe and assist you with some of this. Staff will always use gloves, even if you have a really safe disinfectant as per standard precautions. You're wiping down a surface, you should have gloves on. There's actually a pediatric hospital a couple of years ago that brought in soft-sided packs of disinfectant wipes. And they had a little placard laminated that they could hand the family. This was about a quarter of a sheet of paper. And it just said, family and visitors, feel free to use our disinfectant wipe on hard surfaces around the patient. It's not a baby wipe. Dispose of in the regular garbage. Please do not flush. But they invited family, if they wanted to disinfect surfaces around the patients with something that met that criteria of 000. They never put the onus on the family and visitors. If they, if it's end of life, that's the last thing family wants to be focused on. But I don't know about you, but when I've had family members or friends in the hospital, I'm sitting there with my disinfectant wipes, wiping down everything. I'm reading them the riot act on their hand hygiene and what they need to do. I think everyone listening to me would do much the same thing. You can actually have training cards done up, right, to just direct towards what the therapy staff is responsible for out of the 5 moments, what clinical staff have to do for the 5 moments, what food and nutrition staff have to do. Convenience is going to help a lot. I apologize, this is our product on the things here. I couldn't cover up the little, I guess you can't really read that it's diversity. Anyway, if you can have your disinfectant on that rolling stock that was touched 847 times in 6 days and only cleaned 17 times, I think having the wipes visible will help immensely. And these kind of brackets are available from any wipe manufacturer. Ourselves have them, and I know my competition, the 2 big competitions that we have in the United States, have these kind of brackets. So you can have the wipes visible. You can have reminders up on staff as to what needs to be done through these different care procedures. We've actually developed posters, clean hands and white surfaces work like magic to reduce HAIs. Do your part when you see a patient. You touch it, clean it. As reminders to staff that we all have a role here. It's everyone's job to disinfect. It's not everyone's job to disinfect everything every time. We're all trying to get to zero. An ideal world, and I think it's one of the goals of IAPIC, is to actually have zero preventable infections. So I just want to talk very briefly about adjunct technologies, because we do clean and provide care with human beings. And so there's always this factor of working with a human being. Taddy and I could be taught exactly the same to go in and clean a room, and we're going to do it slightly differently because we're human beings. We're going to do things differently. So we brought in some adjunct technology to help this. Ultraviolet is one of them. And a lot of times what we find is they're only used when a patient has had C. difficile, or they're only used if the patient was on contact precautions. And I find that a little interesting when we do that, because just the use study that showed that you can find 4 to 6% of surfaces in a patient's room having C. diff spores on it after terminal cleaning is a good indication to me that you may want to have an adjunct technology that is sporicidal. And you start factoring in how busy these rooms are. If we're only cleaning once a day, you've got a nurse seeing 4.5 different patients per hour. That's over a couple of rooms. You've got 82.5 people in and out of a room a day. The patient doesn't just stay in the room unless they're mobility impaired or have COVID, because I think we're locking doors on patients right now. Staff go in and out of a room. There's always movement of organisms around, and I've given you enough evidence for that, I think. And a lot of the older UV technology, they're large, they're bulky. We prioritize the C. diff room and the contact precaution rooms because in many times this UV technology needs a dedicated person to do it. So we've been talking a lot at Diversity to have, at a minimum, UVC QDC, or having UVC at every discharge, not just contact precautions. And I think if you start looking at ultraviolet systems here, I know there's a little bit more money coming into healthcare, especially in long-term care. We're having a lot more requests for our UV system, but please look at the systems and try to compare apples to apples. Take a look at how portable it is. Is it easy for everyone to use, or is it just dedicated people? What are the safety features so that people don't get irradiated? How effective is it? We all have our papers to show how much we can kill, and what is the total cost of ownership is vitally important to look at with the adjunct technology. So what I've presented to you here over the past 40 some odd minutes is a concept of I don't think cleaning once a day is enough. I think we need to look at these targeted moments of environmental disinfection. The paper that we had published in the Joint Commission's journal starts with the 5 moments and then provides all the evidence because it's a little easier to read it that way. The presentation, as you saw, is I present the evidence before I get to this because I don't want everybody going, how does he expect me to work this into my day? I think we have to find a way to work it into the day. Healthcare-associated infections are multifactorial. There is a lot of stuff that happens. I showed you 36 different things that can lead to an HAI happening. I've showed you how frequently the environment can be touched through the day. A side rail can be touched 60 times to 120 times to 256 times. Let's just say 60 because that's still a lot. We're going to move bacteria. We've got studies on outbreaks that show how easy it is to move bacteria throughout our healthcare setting and viruses for that matter in our respiratory tract. I think cleaning and disinfection needs to be part of care practices. We really do need to make it, if you've used it, clean it, much more of a mantra for everyone that provides care. We can't allow EVS to take on the sole responsibility for the healthcare environment. Everyone has a role. And I'll say it one more time, it's everyone's job to disinfect. It's not everyone's job to disinfect everything every time, but everyone has a role. So here's a picture of my cute grandson, newborn on the left, about 13 months on the right. And just last week, my son sent me a picture of him in his mask, which he wasn't happy with. And they were just doing this for the picture, obviously. Of all the papers I've talked about, when you get the presentation, I will send this along. These are all the references that were used there in this paper. There are 50. If you have trouble getting any of these papers, please let me know. And like I said, I'm just going to go back up to the Gauthier one here. At the top here, there is a link where you can download this paper for free. I'm not allowed to send it to you. That violates copyrights, but I found out the Joint Commission's journal allows you to download it for free. So those papers are all here. That's my contact information. You had this last time too, and Gail is our rep up in your area there. The diversitydigital.com has a whole bunch of videos and stuff like that. If you put in health or Goche into the search engine, it will pull up other presentations that we have done around some of the topics that I've talked about here. So, are there any questions that have been typed into the chat area? I can't see that without stopping this. I'm just going to leave this up for a second. But maybe, Taddy, can you take a look and let me know if there's any questions?
Yes, Jim, we do have a question. Oh, go ahead, Trent.
Yeah, I typed one into the chat there, and it had to do with your protocol that you talked about with cleaning up stool and going from the spot clean with the sporicidal. Yep. And so I was just wondering what your definition or what your thought of a spot clean with that sporicidal would be. Would it just be kind of where it was visibly soiled? And it just got me thinking about, you know, when staff are in there and cleaning up the patient, they might not be adhering to hand hygiene as strictly to those 5 moments, and so they might be touching other surfaces before doing hand hygiene. And if they're just doing kind of a spot clean with the sporicidal around the patient, if that would lead to some increased spread.
Where in the full presentation that I did on why you don't need to use a sporicide, or at least why Jim doesn't think you need to use a sporicide everywhere, the CDC does state you should use a sporicide in the rooms of patients that are known to be carrying C. difficile. And that's fairly new from just last year. Traditionally, they didn't even say that. There's a lot of other papers out there that say you really only need a sporicide during hyperendemic or outbreak situations. There's 2 papers from the Infectious Disease Society and IAPIC talking about that. So in my presentation, when I looked at the evidence around cleaning, Dr. Rotella did a paper where he was looking at what can kill spores. And what part of his testing was, and in his paper, he summarized that just wiping a surface with a wet cloth will remove almost 3 log organisms. So upwards of 1,000 colonies or spores will be removed just by wiping a surface. I know our disinfectant has about a 2 log kill of spores, which isn't sporicidal at all. Not in, nowhere near is it sporicidal, but we've got papers. That Boyce paper, he reduced his C. difficile from 12 cases to 6 cases without using a sporicide. He just used the improved hydrogen peroxide in the patient's rooms and a very effective cleaning technique. So I get back to, I don't know if we need to use a sporicide on visibly clean surfaces. I think we need to wipe much more frequently and carefully. And I agree with you 100% on hand hygiene, and we need to be very careful with that. The actual cleaning up of visible stool, I don't know why that's not consistent. Everybody's going to be diving for the door if somebody with C. difficile gets a little bit of feces on the floor. Everybody's going to be flipping out and will nuke the entire room. And I'm thinking, well, we don't know who's carrying C. difficile spores. The numbers I'm seeing are as high as 20% of your patients in your hospital that are continent with formed stool could be colonized with C. difficile. And one of my standard lines as an infection preventionist / microbiology tech is there is no such thing as good stool. It's all bad. We need to be very, very consistent in our cleaning. So that's where the targeted moments come from. If I'm assisting a patient with anything to do with feces within that patient bed space, I think there's things that need to be wiped down and disinfected. If it's visibly soiled, if there's visible feces present, yes, it needs to be wiped and disinfected and spot sporicide done. Because the volume, I showed you the number of microorganisms that could be present when it's visibly soiled, right? We're talking the gram again. If it's not visibly soiled, if I change a patient, take them off the bedpan, do their peri-care for them because they're mobility impaired, take my gloves off, I look around, there's no visible feces, my disinfection should be removing 2 to 3 log microorganisms that could be present, and that's the Rotella paper. So there's lots of evidence that just good, effective cleaning is going to reduce things like spores that could be in the environment. Where we have to be very careful, and I'm sure you've all had to address this with staff, is when staff use gloves and don't change them before doing something cleaner. So after providing the peri-care and getting the bedpan out from under the patient or cleaning the patient after they've had their brief change, when I went through this with my son, how do you change a patient out of an incontinence product by yourself? And he says, okay, I put a couple of gloves in my pocket, I put my gloves on, I go in, I tear this down the side, I do this, I do that, I do this, I get the new thing back on, and I cover them up, right? He gave me a 5-minute description of how to change a patient out of an incontinence product. And through the whole thing, he never mentioned changing his gloves. I said, well, when do you change your gloves? And he says, well, after I've done the dirty stuff and I've cleaned the patient's, any feces that's visible on the patient, I clean it off, I look at my gloves. And if they look clean, I keep going. If they're soiled, I would change them at that point before I start remaking the bed or putting a new brief on and this kind of stuff. That's why he has 2 pairs. And I thought to myself, and usually when I talk to in live in front of people, everybody sort of groans a little bit that he didn't change his gloves. But honest to goodness, everyone will do that. Because don't you know, we all have microscopic vision and we can tell if our hands are dirty or not. Hugely concerning. And that's back in my equation, why we should have a written policy on how to change a patient out of an incontinence product. So we know exactly when to change our gloves. And it's not, do they look clean? If you've been handling a soiled brief and providing peri-care, I don't care how good you are, you need to change your gloves before you do the clean aspect of that prep. Now, every nurse listening in here will do it differently because you were shown how the nurse who had you shadowing them that first day that you did your clinical, you're probably going to mimic what they did. And the last time you had a student, they're going to learn your habit of changing a patient out of an incontinence product. And anytime I've asked for a written policy on this, usually the RNs roll their eyes that I work with going, Jim, it's an individual and it's case specific. And I keep saying, all I want is when do you change your gloves? That's all I'm asking for in this process. So does that cover what you asked me? Or was I just on a soapbox and not paying attention?
No, definitely. I think that definitely answers my question. And really helps, I think, give us some of those talking points just to really drive that point home. The other thing that I really appreciated in your talk was about the floors. We are in constant discussion on whether we use sporicidals on the floors or not, but I think it really does just come down to if it's touched the floor, it should be disinfected, period.
Yeah. And my other point on floors is no matter what you do to a floor, because I went through the whole thing of should you just clean it with a good neutral cleaner and a microfiber mop head? Should you use a microfiber mop head and disinfectant in a bucket, or should you go to a sporicidal? Ultimately, as soon as you are done, the floor starts to become recontaminated. So if the patient had C. difficile, and this is the thought, right? The patient had C. difficile, in case there's spores on the floor, I'm going to use a sporicidal. And my thought is, then where do you stop? If you're just going to do the room, 5.5 entries in and out of that room on average per hour, it's going to move stuff from the floor up to the hallway. So do you do the patient's room and the hallway just outside the room? The nurse sees 4.5 patients per hour. Okay, so maybe I should do the next room, because the nurse probably does adjacent rooms. They don't jump over rooms generally, in my experience. I'm a lab tech. My thing always is where do you stop with the disinfectant? The other thing we have to totally stop is regular room floor cleaning should be single mop head, full stop, never re-dipped. What we do in the OR, what we do with contact precaution rooms, where we never take a bucket, even if we re-dip, that bucket never goes to another room if it was contact precautions. Shouldn't. And I like now the microfiber mops that sit in their little thing, solution, whatever you want to actually use. The mop head comes out, it gets wrung out, you put your handle on it, it's sort of a Velcro on the back, you do the room. If the mop head gets dirty or you hit something dirty, the mop head comes off and either gets disposed or goes to laundry, and you take a clean mop head. Yet there are still hospitals in North America that use string mops where even the CDC says you can do 2 to 3 rooms with a bucket of solution. Always do the patient room first, do the bathroom last. And I'm thinking, but the next room, why are you doing the patient room first if you just did someone's washroom? Why don't they get a clean bucket of solution? And that's where people will say, well, if you have a disinfectant in it, saying, no, if you have a disinfectant in it, you mop the floor and then rinse that mop and go back into the patient's room, you've probably overcome the killing effect of your 10-minute quat, which is what most people use to do their floors, maybe a 3-minute. But they can only kill so much stuff before the organic matter inactivates it. So that's where I look at our floor cleaning concept. Sounds good. But from a real microbiology perspective, I don't know how efficacious that's actually being. I would rather see a good neutral cleaner in the room. Like, you have to do your little dry mop first and get up the wrappers and the paper clips and the ends of syringes that fall on the floor and get that crap out of the room. That's easy. Don't create any dust. But we probably should be looking at doing the floors 2 or 3 times a day, just with a good neutral cleaner and a microfiber mop. You do your S swipe thing, get out of the room, and either, again, dispose of the mop head or send it off for laundry. We need to ban string mops and the plunger things that wring out our string mops. I've never seen one that I'm thinking, oh, that looks clean. They always look disgusting. So that's why the company let me put together a presentation on floors. And I found it very interesting because the company, my boss, kept saying, so what are you really saying? What's your evidence? Are you talking about using a sporicide? Without telling me, we just brought to market sodium dichloroisocyanurate, NADCC tablets that are sporicidal in 4 minutes and apparently can be used on floors. So she was a little worried that I'm saying absolutely never use a sporicide on the floor. And I'm looking at my team going, well, I really still don't think you need to use a sporicide on a floor. I think you need to spot clean effectively with a sporicide when there's visible feces. At the most, maybe in a washroom, because we know there's toilet plumes and all this kind of stuff that happens. But for regular use, I felt really bad that the company actually brought something to market that I'm going, it's a good cleaner. It's still a good cleaner. It's a good disinfectant. It's going to kill bacteria too. But really, what's going to get from the floor to the patient? There's another study where they put a phage down, a harmless virus that affects bacteria. And they showed within 4 hours, by doing a 1 foot by 1 foot spot near the patient's bed, within 4 hours, they could detect the phage in the nurse's station. I'm thinking to myself, okay, tell me what the hand hygiene compliance was when they left the room. Let me find out what they picked up off the floor to do that. I know we can aerosolize a little bit of dry material when we move in and out of a room. How frequently were we wet mopping the patient's floor? Give me all of these factors before you start saying the floors need to be disinfected all the time. I always ask a lot of questions, and as Patty said when she introduced me, I've been around a long time. I've been doing this 30 years as infection control, and I've been a microbiology tech, so I understand we live on a buggy planet, right? We're all of you listening to me here have dropped 15 million bacteria in the environment around you here at home or at work as you drop your skin squames. Unless it's really, really hot and you're really, really sweaty, then you don't drop as many skin squames, or you're oily, like I'm starting to get the shine here in my afternoon sun. We got microorganisms all over the place, and that's where, as we worked on this concept of the targeted moments, we actually had 7 at one time, and one of them was if it's visibly soiled. And somebody said to me, that's standard precautions. If there's visible soil, you got to clean that up. I don't care who makes it, you need to clean that up. And I can't remember what the other one was that we removed because it was standard precautions. So we've narrowed it down. And again, Dr. John Boyce had some good input to this. He pushed back on me hard when I talked this concept. He said to me, Jim, there is no evidence that these 5 moments will cut down on HAIs. And I said, Dr. Boyce, with full respect, there's no evidence it won't cut down on infections. And now I'm starting to see papers again as to if you clean more frequently, you tend to have less infections. And to me, that's just common sense, really. We know the whole chain of transmission, and if I can reduce the reservoir, I've broken a link. If I can break the mode of transmission through patient hand hygiene or disinfection of the environment around the patient regularly, it's breaking one of the links. And we know that stops the transmission of a microorganism, and it should stop an infection. So we have up in Alberta, just north of you guys, well, sort of north, the southern Alberta was, just before the pandemic hit, was putting disinfectant wipes in every patient room. And they were going to do an education blitz on the targeted moments of environmental disinfection. I'm actually doing a presentation next week for the northern half of the province on this topic again, and they asked for it. They said, you talked about this a couple of years ago, could you give us an update because we want to implement more frequent cleaning. So it's definitely out there. I think people are, I'm not going to say desperate for this kind of information. It just makes so much sense to me to have this kind of extra cleaning done based on care practices. Just having somebody come around once a day and do a top-notch job and hit 80% of the surfaces with a great disinfectant still had infections occurring in his hospital. And I would love to see the same kind of study done with the targeted moments included into that. Any other comments? If anybody wants to push back, feel free. I tell you, the reviewers, the peer reviewers of the Joint Commission, the first 2 out of the 3 of them said any evidence this is going to reduce HAI. which made me smile. Because there are papers in that 50 some odd papers that did show that increasing cleaning to 2 or 3 times a day reduced the environmental load that's in the environment. Did it really knock back the HAIs? That wasn't the outcome. They were actually trying to stop an outbreak.
If anyone has a question, you can unmute your line and ask Jim your question.
Hi, this is Marwan Swedan from St. Alphonsus. Thank you for the presentation. My question is, can you tell us a little bit about the cost of using an efficient cleaning process? Would that increase the cost for the hospital, personnel-wise, time-wise, product-wise?
Great question. And I get, just because of the diversity product line, we're a little more expensive than other disinfectants. I always tell people the faster the contact time, the more expensive the product's going to be. So your 10-minute quat is pennies a gallon. Our product ain't quite pennies a gallon or pennies a wipe, that's for sure. But what the biggest problem infection preventionists have when you want to bring in a new disinfectant is we do not cost out HAIs well. There's general numbers that you can take from articles that are out there. You know, a Staph aureus, MRSA bloodstream infection, say a CLAB C is going to be about 27,000 US. You know, I've seen these kind of numbers out there. So my problem is if you switch to our disinfectant, like in the John Boyce paper, he reduced his overall infection rate by 23%. That saved the hospital money. So if he actually had, in that chart, if he had what a C. diff infection costs, an HAI C. diff, he reduced that by 6 over 6 months. How much did that save the hospital? Because trust me, that will pay for the wipes. Easy. You know, to have that kind of a safe, effective wipe at bedside, there is a cost associated with it for sure. And when I used to be a frontline IP, every year when I had either my influenza outbreak or my norovirus outbreak, because it always managed to get into the facility and I always had to have an outbreak, and we had extra staff in and we had gowns all over the place and we cleaned more frequently. And after the outbreak, I would go down to my finance guy and say, Jim, is there a code that you can give our outbreak floor for anything extra? Because every nursing unit, when they get a box of gloves up, they get charged for that box of gloves. When they order up a case of disinfectants, they get charged for the disinfectant. They have a payroll for the number of staff that we're on. And what I wanted is anything extra during an outbreak gets a separate code. So at the end of the outbreak, we could say that outbreak of norovirus cost us $250,000. I'm just making up the number. Let's use 100,000. So the outbreak of norovirus cost us $100,000. I need to point out to you, finance person, that the disinfectant wipe we are using had a poor contact time for norovirus. So when it got in the environment, it took really a lot of extra cleaning to get it removed because we couldn't kill it in the environment. And it depends on your disinfectant what the contact time is for norovirus. So one of the last things I did before I left frontline infection prevention is I brought in a wipe that had a 1-minute contact time for norovirus as the clinical wipe. So it was used all the time. And I left. So I have no idea if that actually helped reduce the infections. But I thought if I can prevent 1 norovirus outbreak a year, I paid for that wipe. So that's what we're very, very poor in infection prevention. We don't cost out well for your site that you told me when you introduced yourself. What does it cost you for a CLAB C with MRSA? What does it cost you for a CAUTI? What does it cost you for a wound infection that becomes colonized with MRSA and the patient has to go into contact precaution because they need frequent wound dressing changes? We tend not to keep those numbers. So when somebody says to me, what do you mean you want to go from a wipe that's 4 cents a wipe to a wipe that's 11 cents a wipe? That's going to cost this much over the year because they know exactly how many wipes they used. Or if you're going to increase the number of wipes that are used by this percent, that's going to cost this much. You can't go back to them saying, but if we stop 1 infection of this, that's going to happen. So I'm always challenging infection preventionists and environmental services people that we need to get a lot better at each of our sites at costing out these kind of things. Because then it gives us the evidence that, yes, you know what, to go from the VW Bug 1969 version 10-minute quat to the Prius electric 1-minute contact time effective against viruses, all viruses and bacteria, we're going to pull the hospital into the 21st century, and we will reduce infections because I can keep the surface wet for 1 minute instead of 10 minutes. So it's going to cost more. On the bottom line of your supply chain person, they're going to look down going, holy crap, look at all the wipes you've used. But you need to be able to counter that with it prevented some infections. My rate of hospital-wide MRSA acquisition dropped from this per 1,000 patient days to this, which is worth this much. But right now, could you tell me what a colonization of MRSA costs in your hospital? Do you have a dollar value? Can anyone?
Unfortunately, no. No, I don't have that number, unfortunately.
But you see what I'm trying to say.
Yes.
It's very easy for supply chain to push back going, that's more expensive, you're not going to get it. And I'm thinking, holy crap, we lost a bid. I'll talk in generalities. We wanted to bring in our 1-minute contact time product, and we lost the bid because of price, and they went for a 3-minute product that doesn't kill norovirus. And I thought, holy crap. Based on price, you're putting your patient population at risk of norovirus, and you're going to a 3-minute product that you're probably going to have to use 2 wipes to keep it wet for 3 minutes because EPA and accreditation will come in and check that. You have to follow the contact time on the label. Even Dr. Bill Rotella is now saying that after that wasn't important. He's now saying, no, you have to keep it wet for the contact time on the label. And I, as a disinfectant employee, have to tell you, you have to keep it wet for the contact time on the label. So if you're using our 10-minute quat, I'm sorry, you have to keep the surface wet for 10 minutes. So yes, it might save you money at 4 cents a gallon, but the EVS person is going to take 40 minutes to clean the room instead of 30 minutes to clean the room because they have to keep going back in to wet the surface. And it's this kind of costing that is very, very interesting. The company, when I joined, we have these cost calculators that try to take all this into consideration. To go from a microfiber cloth to a disposable wipe, there's a paper by Weinkin that showed that the disposable wipe saved money because staff didn't have to go back and fill up their disinfectant bucket. We didn't have to spend the time of sending the cloths downstairs to be sorted, to be sent to laundry, to get back up to the floor, because that all costs money too. And the Weinkin paper actually showed going to a disinfectant wipe saved them $37 a day per employee, believe it or not. Even though it was much more expensive, there's other things that we have to factor into this. But it's really hard. And I watch my people. I don't do sales, right? I sit in on these meetings and you see supply chain going, it's too expensive, done. EVS has to cut their budget by 10% across the board because of the pandemic. First thing to go is the 1-minute contact time product, and they go back to a 3-minute contact time product, and they don't tell you that we switched product. And 3 months down the road, all of a sudden you're going, why am I seeing more this and more this and more this? They made their 10% reduction. You're seeing more HAIs. So what did that really save you? And I've talked this long before I got in this role. I don't like inexpensive. I've never liked 10-minute, 5-minute products. And I made this comment at my job interview. I'm glad I'm coming to this company because of the improved hydrogen peroxide product, because I don't like quats. And then I found out that's one of our big sellers is our 10-minute quat. And honest to goodness, 2 weeks ago, I said to my boss, we've got to stop selling a 10-minute quat. To me, it's criminal to have a 10-minute product, especially when I've got schools coming to us saying, we need a disinfectant now to disinfect the children's desks. We want your quat. And I'm thinking, oh, I don't like using quats around kids. It causes allergies. There's all kinds of issues with it. Yes, it would be nice for the company to make the sale. I don't like quats. So yeah, my boss lets me blither on like this all the time. That there are products out there that are very inexpensive that do okay, but there's products out there that just kick butt and do a great job. I see somebody else has added a chat here.
Thank you.
Thank you. Somebody had to jump off. Oh, you're welcome. Thank you for letting me vent. I feel much better.
I have not
Sure.
seen anything either.
Thank you, Jim, for your presentation. I think we're a little bit out of time here, but I would like to give an opportunity for one, if anyone has a last-minute question that would like to ask Jim. Otherwise, we will go ahead and end the call.
Or you have my contact information. Feel free to send me an email. And Patty, I will share the presentation with you. I'll have that to you here just in a couple of minutes.
That is perfect. Again, Jim, thank you so much. This was so informational and all your resources and evidence. That was very impressive. Thank you.
Yeah, thank you, Jim.
Thank you very much for having me.
Yeah, thank you, Jim. Have a good weekend.
Bye now. Thanks.